Good morning. I'm Chris Astill-Smith, and I'm talking to you this morning from London. Today I'm going to be presenting a seminar which we did a few months ago, which took a whole day, and we're going to condense it down into a 1-hour session looking at the main salient points about how to treat and diagnose the menopause. So let's start by having a look at the different muscles associated with the female organs of reproduction. So we're familiar with, of course, the ovaries, the anterior gluteus medius, the middle gluteus medius, the posterior gluteus medius, the gluteus maximus, the piriformis, and the adductor muscles. Muscles also associated with the female reproductive organs, which we must include today, is the adrenal cortex. And we'll be looking at the sartorius and the gracilis muscles there. So let's remind ourselves of how we make our steroid hormones. Let's put that on to number 2. So cholesterol is the precursor, makes pregnenolone. Pregnenolone goes across to DHEA, and progesterone goes across to androstenedione, which is then oxidized to testosterone, and then in turn goes estradiol, or E2, and an alternative route is progesterone to androstenedione to estrone, or E1, and then both of these convert into estriol, or E3. So we'll be coming back to this chart time and time again. So let's have a look at the physiological changes as menopause approaches. So the production of estrogen and progesterone in the ovary starts to decline so that the uterine lining becomes thin and periods become irregular, and eventually they stop. The corpus luteum is responsible for making progesterone and estrogen that the body needs for manufacturing the endometrium, which is the inner lining of the womb or the uterus. When a woman reaches menopause, she will stop ovulating and will not make any more eggs, so this function becomes dormant. Postmenopausal, no ovulation, so therefore no corpus luteum to produce progesterone or estrogen. The adrenals need to take over production of much greater proportion of the progesterone and estrogen postmenopausally. So it's a fallacy that the ovaries actually stop producing estrogen completely postmenopausally. Ovaries still produce some estrogen, but at a lower level, and this is mainly E1 or estrone in the postmenopausal woman. Progesterone, postmenopausally, should remain at the same level as the premenopausal woman in the first 14 days of the cycle. Therefore, the adrenals need to take over a much greater role postmenopausally. Menopause occurs because of the sharp decline in the estradiol and the progesterone production by the ovaries. After menopause, estrogen continues to be produced mostly by the aromatase in fat tissue and small amounts in other tissues such as the ovaries, as we said, bone, blood vessels, and the brain, where it acts locally. So there's 3 phases of the menopause itself. So we've got the period before, or the perimenopause. These are years running up to the menopause, around mid-40s onwards, when symptoms can start. The menopause itself, of course, is only 1 day. Officially, it's 12 months after the last period, the last menstrual cycle. And the post-menopause time, these symptoms should settle down, although some persist for many, many years. So is menopause on the horizon, and how can we diagnose this? So signs of the perimenopause, one of the first hormone changes is a decrease in the hormone inhibin. This is made predominantly in the corpus luteum, and low levels signal to the pituitary to stimulate follicle-stimulating hormone. As inhibin levels decrease, follicle-stimulating levels increase. Activin and inhibin are 2 hormones which are closely related protein complexes, but with directly opposed biological effects. Activin is secreted in the pituitary along with follicle-stimulating hormone. Activin enhances follicle-stimulating hormone synthesis and secretion. Inhibin downregulates follicle-stimulating hormone synthesis and secretion. Therefore, activin and inhibin work directly as opposites. The rise in follicle-stimulating hormone in the late reproductive years before menopause is accompanied by a decline in inhibin and an increase in activin. And here we have a summary of the biological functions of high activin and low activin, low inhibin and high inhibin. And you'll see the principal parts here is high activin. We have high testosterone and low dihydrotestosterone because it downregulates the 5-alpha reductase enzyme. Whereas low inhibin, we have high testosterone, low DHT, because again it downregulates the 5-alpha reductase. But high inhibin does the opposite. We get low testosterone, but we get high dihydrotestosterone because we upregulate the 5-alpha reductase, and this is important to holding on to bone, as dihydrotestosterone is the principal androgen or bone builder in females. So the indicators of perimenopause, we have follicle stimulating hormone is high, activin is high, and inhibin is low. Therefore, follicle stimulating hormone activin will strengthen a weak muscle and inhibin will weaken it. Testing for the perimenopausal period of time in a woman's life, what we'll do is we'll take a strong indicator muscle. First of all, here we use the middle fibers of the deltoid, which are above your head, and then we'll take the gluteus medius, and again we'll do the anterior fibers here because we know that they're weak. And what we'll do is we'll start with follicle stimulating hormone from strength to see if it weakens, which it does, and then we'll test with activin, push above your head, which weakens, and then we use inhibin to see whether that strengthens the gluteus medius anterior division, which it does. So therefore, we can say that Jill is perimenopausal. So elevated inhibin may be a marker for changes in ovarian tissue and, of course, its function. Signs of the perimenopause. When follicle stimulating hormone is high, the ovaries make more estrogen. In menopause, follicle stimulating hormone increases in an attempt to stimulate the ovaries to produce more estrogen. Progesterone is made by the ovaries and increases after ovulation. As a woman ovulates less often, progesterone levels remain low, causing a missed menstrual cycle. So perimenopausal symptoms, as far as the periods or the menses, are heavier, maybe more painful, maybe more frequent, or even longer. Brain fog, insomnia, weight gain, fatigue, hot flushes, which we're going to talk a little bit more at length later, and back and joint pains are just some of the symptoms perimenopausally. Estrogen receptors are all over the body, which leads to a varying amount of symptoms. If symptoms persist after the menopause, this is often related to excessive levels of stress, as we see, which increases cortisol, and therefore we need to look after and nutritionally support the adrenal glands. So premature ovarian failure in an early menopause, follicle stimulating hormone levels can be high, indicating that the ovaries are starting to fail, but the woman may still be getting periods. High follicle stimulating hormone is a sign that the body is not producing enough estrogen to maintain regular ovarian function. When the ovaries begin to fail, circulating estradiol levels drop, could be still having periods, but with symptoms of low estrogen. So looking after the adrenal glands. So when the ovaries reduce their levels of estrogen and progesterone production, the adrenal glands take over as a backup, providing enough estrogen and progesterone to keep women fit and well through the middle life to old age. So now let's have a look at the symptoms of menopause. So we have headaches. We may have systemic weight gain, night sweats, palpitations, breast enlargement and pain, skin hot flushes, dryness, itching, thinning, joint soreness and pain, urinary incontinence, urgency, psychological problems like dizziness, interrupted sleep, anxiety, poor memory, depressive moods, etc., shorter or longer cycles, bleeding between periods, vaginal dryness and painful intercourse. Not necessarily all of those, but these are some of the symptoms that may manifest menopausally. So in summary, perimenopause generally is indicative of high estrogen or one of the estrogen metabolites, as we're going to talk about. And this equates then to high follicle stimulating hormone, high activin and low inhibin. Postmenopausally is usually associated with low levels of estrogen, and therefore we see high prolactin, which we'll come into in a minute, low progesterone and low luteinizing hormone. So the general difference is perhaps perimenopausally we may have high estrogen or its metabolites, and postmenopausally we have low estrogen and high prolactin. So two of the common changes menopausally or postmenopausally is the extracellular matrix. So we look at collagen and elastin. So lack of collagen can affect the skin. In postmenopausal women, the skin thickness decreases by 1.13% per year, with an associated decrease in collagen content of about 2% per year. It leads to an increase in wrinkles, dryness, decreased skin firmness, and lack of elasticity. So to test for collagen, as we'll see in a minute, we do a positive sustained challenge or skin tug test, which is what I'll demonstrate in a minute. And when you hold that skin, which has 3 different types of collagen in it, this is the same collagen that's in joints, muscles, and soft tissues. We challenge against zinc, proline, lysine, glucose, galactose, iron, vitamin C, manganese, vitamin A, sulfur, maybe as MSM, zinc, copper, pyridoxal 5-phosphate, the active coenzyme B6, bilberry extract, silicon, and vitamin E. These are all the cofactors which are necessary to build precursors and cofactors to build collagen. Elastin, progesterone, modulates the production of elastin. Fibrous protein forming elastic mesh and imparts yellow color and skin and in the aorta and the other tissues, the elastic tissues in the body. So the main hormone here that modulates elastin production is progesterone, and of course this is decreasing postmenopausally because there's no corpus luteum being produced. So the test for elastin is what I call the twang test, which we pull the skin and then we let it go. And that recoil there is, I call the twang test. If that's positive and the strong muscle goes weak, then challenge against glycine, alanine, valine, proline. These are the precursors to elastin. Copper, which is the cofactor. Bilberry, progesterone, maybe as progesterone as a natural hormone or as progesterone cream. Pyridoxal 5-phosphate and vitamin K2. So let's have a look and demonstrate that now. Right, so now we test collagen. So what we'll do is we'll take a strong indicator muscle and we'll test here with the middle fibers of deltoid. So push the elbow above your head, if you will, against me. Good, and what we'll do now on the skin on the back of the hand there is we'll give it a tug. So it's a sustained tug, so you keep hold of it, then we come back to the deltoid muscle and push it above your head again. So that's for collagen, and then to do the elastin, it's the twang test. So if we pull it out again, and then let it go, and then retest the muscle here, and again, the strong muscle remains strong. So collagen and elastin are integral, or fine.
Good.
What would be the word?
Optimum.
Right, so psychological and emotional problems, generally caused by fluctuating levels of the estrogen and the progesterone, but they can be due also to neurotransmitter imbalances, especially dopamine, serotonin, and noradrenaline, norepinephrine. So typical symptoms might be residual worry or tension, feeling of restlessness, palpitations, poor concentration and memory, inability to think clearly, difficulty prioritizing, panic attacks, shallow breathing, and sleep disturbances. So brain fog and poor memory are common symptoms which are complained about. Estrogen receptors support neural function, and declining levels have an impact on the ability to absorb, process, and retain information. And this may manifest as low glutamate, which is a neurological input through the 5 senses, and this would affect learning and memory, and this we pick up at triple warmer 23. Low noradrenaline, which would be small intestine 19, would lead to poor concentration. Low acetylcholine, which we pick up on gallbladder 1, supports thought processing and learning and recall. Low dopamine would be conception vessel 24, which is the hardwiring of the memory, and low serotonin on bladder 1. These are all the beginning and ending points of the yang meridians, as we'll see, which are associated with low levels of these different neurotransmitters. So the yang points indicate neurotransmitter deficiencies on the face here, and the yin points tend to indicate neurotransmitter excesses, which will begin or end on the trunk. So dopamine, low dopamine, which we pick up on conception vessel 24, impaired cognitive function, memory, learning problems, difficulty problem solving, low motivation, depression, no feelings of pleasure, lethargy, chronic fatigue. High dopamine, which we pick up on governor vessel 27, can lead to anxiety, restlessness, overstimulation, feeling nervous, insomnia, and paranoia. And here we see a chart of how we produce dopamine from tyrosine. And we'll be coming back to this, particularly this area here, a little later on when we look at hot flushes. So nutrition generally for dopamine when it's underactive would be tetrahydrobiopterin, vitamin D, pyridoxal 5-phosphate, magnesium and zinc. Key nutrients for overactive at Governor vessel 27 would be FAD, the coenzyme of vitamin B2, and copper, involved with the hydroxylation of these brown chemicals. S-adenosylmethionine for methylation, which may require methylcobalamin, 5-methyl tetrahydrofolate, betaine, zinc. And for conjugation would be glutathione or sulfur or glucuronidation or acetyl-CoA. So noradrenaline is very similar in its synthesis to dopamine. So low noradrenaline, small intestine, may lead to depression and low arousal, low get up and go. High noradrenaline would be anxiety, heart palpitations, because we manifest high noradrenaline of heart 1. Maybe high blood pressure, headaches, anxiety, panic, and nervousness. So we see here from the chart, again, the precursor is tyrosine, making L-DOPA to dopamine, and then dopamine being hydroxylated to making noradrenaline or epinephrine. And then the same pathway for metabolizing the noradrenaline through monoamine oxidase and methylation and conjugation. So nutrition for underactive noradrenaline, again, tetrahydrobiopterin, vitamin D, P5P, magnesium, zinc, but in the last pathway, the hydroxylase pathway requires vitamin C and copper. Overactive at the heart 1 meridian is exactly the same as with dopamine, FAD and copper for hydroxylation, S-adenosylmethionine here for methylation, and glutathione, sulfur, glucuronidation, acetyl-CoA for conjugation. And the last of the big three is serotonin, which is associated with low serotonin on bladder 1, can lead to depression, colloquially called the blues, because in the wintertime we don't get enough of the violet end of the spectrum, so we get predominantly the blue end, and this leads to depression of serotonin. And high serotonin, kidney 27, can lead to anxiety. High levels can also reduce libido. So here we see serotonin being made. The precursor in this case, of course, is tryptophan as opposed to tyrosine, but the process is the same: hydroxylation, decarboxylation, and then the metabolism of serotonin involves monoamine oxidase, methylation, and conjugation. So key nutrients for serotonin to build it up: tetrahydrobiopterin, vitamin D, pyridoxal 5-phosphate. And here we've added 5-hydroxytryptophan, 5-HTP, as a compound halfway in the metabolism here, or halfway in the synthesis of making serotonin. Usually comes from Grifolia seed, magnesium, zinc, and then overactive serotonin at kidney 27. Same things: hydroxylation, methylation, conjugation. So those three have very similar enzymes. The only difference is that tyrosine is the precursor, and tryptophan is the precursor to serotonin. So estrogen is the protective hormone which can improve psychotic symptoms as well as depression. Estrogen directly influences the neurotransmitters serotonin and dopamine to achieve this positive effect. Estrogen increases serotonin, also makes it work better and results in improved mood. This means that if someone has lower estrogen, you can counteract these effects by increasing serotonin directly with supplements like 5-HTP. So additional nutrients that may be required here: essential fatty acids, especially the omega-3, flaxseed, DHA, or omega-3. Vitamin D, as we mentioned, and in this case it would probably be D3 as opposed to D2 in this particular case. Probiotics to support the gut connection, and a couple of spices, fenugreek and turmeric, have been shown to help with menopausal depression. Now, vaginal dryness and atrophy are often common problems. In the vagina, the tissue becomes drier and thinner. This can lead to urinary infections and atrophy and shrinkage of the vaginal tissue. And again here, our favourite is sea buckthorn, otherwise called omega-7 oil, which technically is called palmitoleic acid, which happens to be also rich in macadamia nut oil. The sea buckthorn oil, or omega-7, helps with the dryness in the vagina, as we'll see postmenopausally. So let's briefly look at bone. This is always a big issue. Bone. It contains, as you know, both organic and inorganic material. The principal protein of bone, of course, remember, which is the scaffolding for the minerals to attach to, is collagen. So 90% of the protein in bone is collagen, and some non-collagen proteins which are specific to bone. For example, osteocalcin. So osteoblasts deposit new bone and are stimulated by the androgens. So testosterone, but particularly here is dihydrotestosterone. This is the main osteoblast builder. Dihydroepiandrosterone, DHEA, and progesterone. So these are all the androgen effects. Vitamin D, a D3 in this case, and vitamin K are very important for osteoblastic activity, but usually you need to test them together. So sometimes you find that vitamin D doesn't show, vitamin K2 doesn't show, but when you put the two together, as vitamin D3, K2, and then the muscle goes strong. And this is the main combination, as we'll see later, for stimulating bone growth and osteoblastic activity. Osteoclasts, on the other hand, reabsorb old bone and are stimulated less so by vitamin D, but are inhibited by estrogen. And this is how hormone replacement therapy works, because it decreases the reabsorption of old bone. So ultimately, with hormone replacement therapy, after as years go by, the lady is left just with a lot of old bone and not stimulating new bone from the osteoblasts. So the main bone builder in females is dihydrotestosterone. Inhibin stimulates 5-alpha reductase, thus increasing dihydrotestosterone levels. So in a sense, high inhibin stimulates the conversion of testosterone into dihydrotestosterone, whereas high activin, which we get in the perimenopausal period, inhibits 5-alpha reductase, thus decreasing dihydrotestosterone, which may lead to the effect of osteopenia and eventually osteoporosis or bone loss. We've mentioned a lot about vitamin D in there. An interesting fact here is that vitamin D inhibits serotonin synthesis in the gut. Vitamin D inhibits serotonin synthesis in the gut. It enhances serotonin synthesis in the brain. So we see that the tryptophan hydroxylase that converts tryptophan into 5-hydroxytryptophan, there's two forms, tryptophan 1, hydroxylase 1 and 2. And the one in the gut here is actually inhibited by vitamin D. And here the tryptophan hydroxylase 2 in the brain is stimulated by vitamin D. So now we can see why a lot of people actually feel much better mood-wise when they take vitamin D, especially when the times of low sunshine levels and low violet wavelengths in the air. So looking at bone, positive therapy localization to the bone, sometimes very difficult with osteoporosis, but I like to use Joe Schaefer's technique of using the tuning fork. So we hit the tuning fork, put it on a bony prominence like the greater trochanter. If a strong muscle goes weak, test it against bone meal. This is a ground up bone mixture, just to see that it is the bone which, the compounds of the bone which negate this, and then challenge it against the precursors to collagen, like glycine, proline, lysine. And in this case, the minerals that attach to the scaffolding, like calcium, magnesium, silica, zinc, and copper. Boron is very good as it stimulates estradiol and testosterone in postmenopausal women. So boron may come in as an essential nutrient at this time. Vitamin C, which of course is important in collagen, vitamin D, vitamin K2, and often, as I said, D3, K2 together, also known as Activator X by Weston Price back in the 1940s. And some forms of bone formula products can be very helpful to. So let's demonstrate this. Right, so testing for bone density. We're going to take a strong indicator muscle. In this case, we use the middle fibers of deltoid. And what we do is we tap it in the fork, and we put it over the greater trochanter, and then retest the muscle, and she goes weak. So what we do is we do a few nutrients to see what improves the bone density. So we start up here with vitamin D3. So vitamin D3 doesn't strengthen. And then we do vitamin K2. K2 doesn't strengthen. And then we'll do bone formula. It's a combination of all the minerals for the bone, and that's nice and strong. And then we'll do collagen, which is a mixture of collagen factors here. And finally here we'll do vitamin C. Good. So bone formula strengthens. So let's confirm that one. Okay, let's confirm it. Okay, tap on the greatest counter, bone formula on, and bone formula strengthens. So that's a good product for you. So, along with vitamin D, of course, sometimes people have very high levels of vitamin D, but it doesn't seem to be effective. And this can be because the vitamin D receptor is blocked, often with toxic metals and chemicals or lack of the essential fatty acids. So we need to sometimes look at the vitamin D, the VDR, the vitamin D receptor. It's a protein which is activated by the vitamin D, which attaches itself to the DNA and thus influences what proteins are made from our genetic code. So this is a receptor on the nuclear membrane, not the cell membrane, but actually on the nucleus, and directly then affects the genetic code. Researchers found 2,776 binding sites for vitamin D receptor along the length of the genome. So vitamin D is far from just associated with blood calcium levels, with many, many different functions, many proteins which are dependent upon adequate amounts of vitamin D. And the question is, the intake may be fine, the exposure to sunshine may be fine, but there may be a problem with the vitamin D receptor. So things that can stimulate or activate the vitamin D receptor is resveratrol, omega-3, magnesium, zinc, quercetin, non-daily vitamin D. I think the reason for this is high levels, low levels of vitamin D tend to stimulate the receptor, which would be more compatible with what we get from the sunshine. So you get periods of time when you go out in the sun, periods of time when it's cloudy, when you don't get enough sunshine. So this is the more natural way. Perhaps in the case of vitamin D receptor, they found that non-daily vitamin D, taking it periodically during the week, seems to stimulate the receptor better. Boron, sulforaphane from cruciferous vegetables, intense exercise, ginger, cumin, thyme, coriander, lemongrass, and of course ultraviolet light. Glucocorticoids, in other words cortisol, are known to decrease the expression of the vitamin D receptor, which is expressed in most tissues of the body and regulates intestinal transport of calcium, as we know, but it's also vitamin D regulates phosphorus, iron, and many other minerals, probably magnesium and possibly zinc as well. So vitamin D deficiency may influence menopausal symptoms by optimizing low progesterone levels, low dopamine levels, low serotonin levels, low nitric oxide levels, and low glutathione levels. So you can see why vitamin D is such an important component to look at for around perimenopausal and postmenopausal. So let's have a look now. So now we're going to test for vitamin D, the need of vitamin D. And for this, we're going to take a weak muscle and bring the heel up towards your bottom, in this case, the sartorius, and we're going to challenge her with activator X, which is the indicator we're going to use for deficiency of any form of vitamin D. So put the heel up towards your bottom, which it strengthens. So now we can go through the different forms of vitamin D, vitamin D2, vitamin D3, and the different hydroxylated forms to find out the ideal form that she needs. But the activator X is a good indicator that she's deficient in vitamin D. So let's look at progesterone and estrogen synthesis, in other words, how we make these two hormones. Again, back to our chart here, cholesterol to pregnenolone, pregnenolone along here to DHEA, and then down to androstenedione, testosterone, estradiol, E2. Alternative route is progesterone across here to androstenedione, down to estrone or E1, and then these two forming estriol or E3 coming together. Now this picture is what happens to the estrone, the estriol and the estradiol after we synthesized it. After it's attached, we have to metabolize it or get rid of it. And this looks very complicated, but in fact it's very straightforward. So the hydroxylation is the first pathway here, just like we met in serotonin and noradrenaline and dopamine, hydroxylation by cytochrome P450 enzymes here, okay, which require an ADPH and iron. Then the second pathway, we've made our hydroxylated derivatives, and the real bad guys here, or bad girls, will be the 4-hydroxyestrone, 16-hydroxyestrone, and the 4-hydroxyestradiol. And these are very much more pro-proliferative, in other words, tend to stimulate the growth of malignant tumours. All these hydroxylated derivatives are then methylated by an enzyme called catechol-methyltransferase, or COMT for short, and then they all use SAM, acetylsylmethionine, as the methyl donor. And to recycle and synthesize SAM, we may need methylcobalamin, 5-methyltetrahydrofolate, betaine, and zinc, as you can see there. Then the methoxylated derivatives here of estrone and estradiol are then generally conjugated by glutathione, glucuronate, sulfation, and acetylation. So this way we can work backwards and find out exactly where the blockage is. So the main pathway with menopausal type of symptoms is the conversion of the hydroxylated derivatives into the methoxylated, which is inevitably due to a deficiency of catechol-methyltransferase methylating enzymes. If we've got a deficiency of that, we're going to build up of the hydroxylated derivatives. And if we've got an overactive catechol-methyltransferase, then we get a build up of the methoxylated derivatives, which are more benign but are pro-proliferative insofar they produce and stimulate more benign tumours like fibroids, etc. So catechol-methyltransferase is an enzyme. Its name implies that the COMT enzyme transfers methyl groups to catechol-containing compounds. In other words, it methylates them. It uses a compound called S-adenosylmethionine, or often called SAM for short, or SAMe, as the methyl donor, meaning that the adequate amounts of SAMe is required in order for COMT to work properly. Methylation by COMT helps break down or metabolize estrogen compounds naturally produced, including, as I mentioned, the 2, the 4, the 16 hydroxylated estrogens, the 2, the 4, the 16 hydroxylated estradiols. So low COMT increases the risk of malignancy, and high COMT increases the risk of benign tumours and growths like fibroids. So let's have a look at this. Right, let's test now for COMT methylation pathway. So if we do this, what we'll do is we'll take a weak indicated muscle first of all. So push out with the left leg, so we'll do the anterior fibers of the gluteus medius there. And we'll put the COMT on here and see if it strengthens. Push out, and it doesn't. So we know then it doesn't strengthen, and therefore she's not under-methylated. So if we take a strong indicator muscle, in this case we'll use the rectus femoris, leaving the COMT on, and the strong muscle now goes weak. So that means she's got an excess methylation pathway at this particular present time. So testing for high estrogens then, a strong muscle weakens to estradiol or estrone, or to load them, it could be estradiol and estrone together. So sometimes the patient weakens to only the estradiol, estrone when they're together. And also testing them for the hydroxylated metabolites of estradiol and estrone, and lastly the methoxylated metabolites of estradiol and estrone. Suggested remedies here, the main one interestingly is iodine. We may be short of hydroxylation, the iron and NADPH, methylation and methylation cofactors, in other words SAM, and may require more methylcobalamin, 5-methyltetrahydrofolate, betaine and zinc, and conjugating nutrients like glutathione, sulfur, glucuronic acid, and acetyl-CoA. So testing, on the other hand, for low estrogens, which are more postmenopausal, using a weak muscle, as we saw the gluteus, anterior gluteus medius in the case, is the muscle that we're using as a weak muscle. Check if strong to estrone or estradiol, or E3 estriol. Estrone is the predominant one postmenopausally, as we know. If strengthened, then the patient is low in the particular estrogen. Need to find where the blockage is, so test the precursor working backwards from the low hormone. Do this from a strong indicator muscle to find which one weakens. This is the substance which is in relative excess. For example, strong to estrone but weak to androstenedione means we've got a problem between the conversion of androstenedione to estrone. Use this weakness to find the remedies. Again here, suggested remedies. The vitamin B coenzymes like NAD, NADH, NADP, NADPH, FADH2, the reduced form of FAD, or vitamin B2, iron, vitamin E, or wheat germ is a very good source, good wheat germ oil capsules, not wheat germ as an oil because it goes rancid very quickly, magnesium and boron, firstly postmenopausally. we test for the estrogens, E1 and E2. The predominant one is estradiol and estrone. So we'll take our weak indicator muscle, our gluteus medius, push out. And we'll take our strong indicator muscle, which we're using in this case the deltoid, push above your head. And what we'll now do is we'll test to see if she strengthens to estradiol. So we'll put the estradiol on, and then we'll push out with the leg, and it doesn't strengthen. So, and then we'll go to estrone, or E1, and push out, and that strengthens, which means she's deficient in estrone. Then we'll go back to the precursor or substrate to estrone, which is androstenedione. So we'll put androstenedione, and then we'll take our strong indicator muscle and push above your head, and it goes weak. So that means that's in relative excess. So our relative excess is androstenedione, and our deficiency is estrone. And then we'll find the nutrient or nutrients that negate that. So we'll start off with NADPH, push, and then we'll do FADH2, the active coenzyme of vitamin B2. And then we'll do iron. We'll use iron citrate in this case. And then we'll challenge for magnesium citrate in this case. And then we'll challenge for boron, which will go over your head. Very important in postmenopausal women for producing the estrogens. And finally, wheat germ oil as a source of vitamin E, which does strengthen. So vitamin E is needed here, or certainly wheat germ is a source of vitamin E. It would be beneficial.
So in some cases, perimenopausally, as we change the conversion of perimenopausal to postmenopausal, we get estrogen dominance. In other words, we get a high amount of estrogen being produced and less of it being metabolized. So generally, estrogen levels are decreased during the perimenopause. These levels do not fall appreciably really until after the last period. Many women suffer from estrogen dominance during this transition phase, in other words, high levels of estrogen. That is, they have too much estrogen relative to the progesterone. Some women can suffer from estrogen dominance for 10 to 15 years before the menopause. And the symptoms are very similar, or maybe that's what it is premenstrual syndrome, as well as those menopausal symptoms. So estrogen is the dominant hormone in the first 2 weeks leading up to ovulation. Estrogen is balanced then by progesterone during the second half. And ovulatory cycles where estrogen can go unopposed, or if low progesterone, this can lead to estrogen dominance. Causes generally of estrogen dominance: excess body fat, because body fat produces the estrogens; too much stress, in other words, high cortisol, insulin, and noradrenaline; low fiber diets, so not enough fiber to detoxify excessive carbs, leading to high blood sugars; and many environmental agents such as toiletries, cosmetics, which are full of xenoestrogens. So to test for estrogen dominance, we weaken to the combination there. We challenge the person with estrone and estradiol together. So suggested nutrients for estrogen dominance, again, would be those that help to metabolize it: iodine, zinc, magnesium, iron, NADPH, pyridoxal 5-phosphate, vitamin E or wheatgrass, wheat germ, essential fatty acids, and if necessary, adrenal tissue extract.
Right, testing for estrogen dominance. We'll first of all take a strong indicator muscle, push above your head, and we'll put on E1 or estrone on its own first of all. Push above your head. And then we'll put on E2 or estradiol, push above your head. And they both remain strong. And then we'll load it by putting both on. And it's that time which we're checking really for estrogen dominance. So we're loading the system there. And what we'll now do is the most common nutrient we find for estrogen dominance here is iodine. So iodine negates the estrogen challenge there using the estrone and the estradiol together.
So estrogen has a big impact on the thyroid gland. Estrogen competes with thyroxine at receptor sites, so estrogen in overload or excessive amounts can lead to symptoms of underactive thyroids, in other words, weight gain and feeling the cold.
Detoxification, as we talked about, of estrogen derivatives, really is in those three stages that I talked about: hydroxylation, methylation, and conjugation. And many health problems are associated with these different derivatives. Now, one of the major symptoms that women complain about, more than probably anything else, is hot flushes. And this is quite interesting from a research point of view, to actually work out what it is that causes the hot flush itself. What is the mechanism? What is the biochemistry of the etiology of hot flushes? So let's have a look at hot flushes first of all. And I get this often with patients who come to see me about menopausal symptoms. And if I'm really, really lucky, I get the woman actually experiences a hot flush when they're in the clinic itself, in which case I can directly test them with these different compounds to see what it is that mediates it. And these are my ideas, which I formulated, which I want to talk to you about. So hot flushes affect probably about 70% of menopausal women, with up to 20% of these women describing them as intolerable. Furthermore, hot flushes can last as long as 20 years. That's not one hot flush. What that means is it can go on for 20 years postmenopausally, therefore having a significant long-lasting effect on the quality of life. Hormone replacement therapy is the mainstay treatment, but confers an increased risk to other diseases, as we know, like breast cancer, thromboembolic diseases, and cerebral and cardiovascular disease. Hence, current recommendations suggest a limited duration of HRT in all women and contraindication in specific groups. Those who've got a history of thrombosis and strokes, etc. Other drug alternatives, such as selective serotonin reuptake inhibitors, are less effective than HRT. Therefore, effective non-hormonal treatments are required. So hot flushes, or sweats, the exact cause is a vasomotor symptom, has not been fully identified. Associated with estrogen withdrawal, but not the primary cause. Maybe due to changes in the hypothalamus, control of body temperature, regulation. And the principal two nuclei that do this is the preoptic nucleus and the anterior hypothalamic nucleus. And both of these nuclei are involved with body thermoregulation. Possible causes, mechanisms are sympathetic nervous system. Well, we know that in the sympathetic nervous system is the beta receptors which are involved with skeletal vasodilation. Parasympathetic nervous system works primarily more locally by nitric oxide release. Also things that are implicated, prostaglandin D2, which may be part of the reason why some of the essential fatty acids are very important and can relieve symptoms, and vasoactive intestinal peptide, VIP. So it could be that the lower hormones affect the hypothalamus, which regulates the body temperature, confusing it to identifying an increase in body temperature. Body tries to cool itself down by dilating the blood vessels, causing flushing, and then activating the sweat glands. So symptoms of the hot flush, from the clinical research point of view of my own work over the years, is I always find that ladies with hot flushes are all test positive and high in prolactin, which is a primary pituitary hormone. We know that high dopamine suppresses prolactin. So therefore low dopamine, which we pick up at conception vessel 24, could be allowing the levels to rise. So here we've got a situation where low dopamine allows prolactin to go up, high dopamine keeps prolactin down. So the most common remedy, as we'll see to this, is pyridoxal 5-phosphate, which is the active coenzyme of vitamin B6. And this is why B6, or pyridoxal 5-phosphate, seems to be the main nutrient that we find which helps to relieve the symptoms of hot flushes. Now this is a chart that I put together, and here we've got the amygdala, which of course is the part in the hippocampus and the limbic system, which we call stress. And we know that this stress level has a positive stimulatory effect on the paraventricular nucleus in the hypothalamus, which produces thyroid-releasing hormone. Thyroid-releasing hormone obviously also stimulates thyroid-stimulating hormone in the pituitary, but it has a tonic effect on the production of prolactin in the pituitary and tends to favor postmenopausally this pathway, which is ironic because the lady is high in prolactin but low in thyroid-stimulating hormone and gets cold. So these people often get cold hands and feet, but suffer with hot flushes. High prolactin in turn decreases progesterone and decreases estrogen, whereas low progesterone stimulates the production of prolactin. So postmenopausally, because we've got low progesterone, especially if you're not ovulating anymore, we're having to rely upon progesterone being produced by the adrenal cortex. And if that's rather tired and can't produce enough progesterone, this stimulates the production of prolactin, which adds to the hot flushes. On the other side, the amygdala also has a stimulatory effect on the suprachiasmatic nucleus. This is the fundamental circadian rhythm body clock. And the suprachiasmatic nucleus directly sends fibers to the arcuate hypothalamic nucleus, which is the main center for gonadal releasing hormone. And here we see that prolactin, high prolactin, inhibits the production of gonadal releasing hormone. Therefore, again, we get low follicle stimulating hormone and luteinizing hormone from the ovary area and also the adrenal cortex postmenopausally. The arcuate hypothalamic nucleus stimulates the production of prolactin releasing inhibiting hormone, which is otherwise known as dopamine. So dopamine produced here in the hypothalamus is called prolactin releasing inhibiting hormone because it inhibits the production of prolactin or regulates it. So it's probably better to say regulates or keeps it in balance. So here, the lower the dopamine, the higher the prolactin, and vice versa. So the real regulator of the whole menopausal situation is dopamine, because it has this regulatory effect on prolactin. And we know that we met earlier, dopamine is made from the amino acid tyrosine by hydroxylation and decarboxylation. So let's have a look at that in a little bit more closer detail. So tyrosine here, we can see here hydroxylation requires tetrahydrobiopterin, vitamin D, copper, iron, and sulfur. Converts by hydroxylation to L-DOPA, and L-DOPA then decarboxylates or loses the carbon dioxide to make dopamine or prolactin-releasing inhibiting hormone. And the main cofactor here, coenzyme, is pyridoxal 5-phosphate. And to stimulate cofactor by zinc, glutathione, most importantly here, light. And the question is, what sort of light, what sort of wavelengths, as we'll see, can actually stimulate the conversion of L-DOPA into dopamine, and we'll see that it's in the violet end of the spectrum. So dopamine released from the hypothalamus cells travels via the blood supply to the pituitary portal system and then to the anterior pituitary, where it tonically suppresses the release of the hormone prolactin. Drugs that interfere with the release or actions of dopamine can cause lactation as a side effect, even in men. So let's have a little look at prolactin, because prolactin is a real heavy-duty hormone. It's often forgotten about because it's always associated with lactation in women and then forgotten about for its other purposes. It's secreted heavily in pulses, and this is important, that it's actually secreted in pulses. It's not continually produced, it's in pulses. Prolactin plays an essential role in metabolism, regulation of the immune system, and pancreatic development. As a growth factor binding to cytokinase receptors, it influences hematopoiesis, another secretion of blood cells, and angiogenesis, and is involved in the regulation of blood clotting through several pathways. In general, as we've said, dopamine inhibits prolactin. Elevated levels of prolactin decrease the levels of the sex hormones, especially estrogen in women and testosterone in men. So elevated levels, high prolactin, which we pick up off Governor Vessel 27, decrease the levels of sex hormones in both men and women. The effects of mildly elevated levels of prolactin are much more variable. In women, substantially increasing or decreasing estrogen levels. So mildly elevated levels can increase or decrease estrogen production. Hyperprolactinemia, or excess prolactin, is associated with hypogonadism. In other words, the higher the prolactin, the lower the gonad function. Anovulatory infertility, oligomenorrhea, amenorrhea, unexpected lactation, loss of libido in women, and loss of erectile function and libido in men. In humans, prolactin is produced at least in the anterior pituitary, with the deciduum, which is the maternal part of the placenta, myometrium, breast, lymphocytes, leukocytes, and prostate in obviously the male. Prolactinemias may disrupt the hypothalamic pituitary gonadal axis, as prolactin tends to suppress, as we saw, the secretion of gonadal releasing hormone from the hypothalamus. and in turn decreases the secretion of follicle-stimulating hormone and luteinizing hormone from the anterior pituitary, therefore disrupting the ovulatory cycle. So if we go back here to the chart that I put together, we've got high prolactin here, which is basically when this is high, it inhibits the gonadal releasing hormone from the arcuate hypothalamic nucleus, which then inhibits the production of follicle stimulating hormone and luteinizing hormone, which primarily is why breastfeeding mothers, it's very difficult to get full pregnant again because they're not producing enough of the follicle stimulating hormone and luteinizing hormone. So breastfeeding mothers tend not to get pregnant very easily. So it's a natural birth control. So governor vessel 27 is high dopamine equals low prolactin and high estrogen, whereas conception vessel 24 is low dopamine and high prolactin and low estrogen. So thus hot flushes and autoimmune disorders are picked up off conception vessel 24. So a person with hot flushes will often therapy localized to conception vessel 24, which indicates low dopamine and high prolactin. So the hypothalamus controls the immune system. At night, the hypothalamus triggers the pituitary gland to produce prolactin. Prolactin triggers the thymus to program white blood cells like the lymphocyte T cells to know the difference between self and non-self. Prolactin secretion peaks about 3 hours after melatonin peaks and lasts for about 8 hours. Dreaming is influenced by prolactin, but dopamine allows us to remember our dreams. If the secretion is dyscircadian, in other words, high during the day instead of high at nighttime, the lymphocytes are more likely to attack self-tissue, leading to autoimmunity and blockage of steroid receptors. My experience, all autoimmune problems show at low dopamine and a high prolactin. So here we see melatonin in the red here, peaking at about 2 or so in the morning, followed by prolactin peaking at 6 o'clock in the morning. And what it's saying is this: if we have this dysregulation, circadian rhythm, and we're high during the day instead of high at nighttime, we'll produce more lymphocytes, which will, could attack our own tissues. So here we test prolactin from weakness and also from strength. So let's challenge now for low levels of prolactin. So we'll take a weak muscle, which we use as an indicator, and we'll place on the prolactin, and we now bring the heel up to the bottom, and we go strong, which indicates that Jill is low in prolactin. So now what we do in the clear, we can test with a strong indicator muscle, governor vessel 27, which indicates a high level of dopamine, which equates with low prolactin and high estrogen, so full. And that confirms that the governor vessel 27 is related to dopamine and prolactin. So here's a few articles: heart attacks linked with hot flushes and night sweats. The causes of hot flushes are likely to be neurovascular, as we know. Endocrinologists believe that they result from changes in the part of the brain that regulates body temperature, in other words, the hypothalamus. Possible triggers for hot flushes include eating spicy foods, drinking coffee, alcohol, wearing clothing that's too warm, having high temperatures, smoking, stress, some medical treatments, other health conditions like diabetes, but often is without any apparent treatment. Now, the $100 question is the mechanism. So vasodilation occurs when the smooth muscles in the blood vessel walls relax. And relaxation of this can be numerous stimuli due to acetylcholine, adenosine, noradrenaline, as we say. But most of these endothelial nitric oxide synthase through the acetylcholine are mediated by nitric oxide itself. Sympathetic nervous system does cause vasodilation in the muscles, but only on the beta receptors, not the alpha receptors. Vasodilation by the parasympathetic only occurs in certain nitric oxide released local vascular tissues. It wouldn't explain the systemic hot flush which many women suffer from. On the other hand, vasointestinal peptide, VIP, is produced in many tissues, including the suprachiasmatic nucleus of the hypothalamus and some autonomic nerves. VIP stimulates contractility in the heart. It causes vasodilation. It increases glycogenolysis, lowers arterial blood pressure, and relaxes the smooth muscles of the trachea, stomach, gallbladder.
Most importantly here, VIP has a half-life in the blood of about 2 minutes, which is roughly the time that a hot flash takes hold before it disappears. VIP is known to mimic the effects of beta-adrenergic receptor stimulation in rats. So VIP and beta-2 adrenergic receptors activation may share the same post-receptor mechanisms. VIP in the pituitary stimulates prolactin. Additionally, the growth hormone releasing hormone is a member of the VIP family and stimulates growth hormone secretion in the anterior pituitary. And this is the danger with high prolactin. Often you get high growth hormone released as well. Current data may suggest that the origin of the neurovegetative symptoms lie within the hypothalamus. So VIP. So looking back at our chart here, growth hormone, gonadal releasing hormone being suppressed by prolactin. So key nutrients to consider overall for the menopause: pyridoxal 5-phosphate, vitamin D, vitamin D3, K2, zinc, magnesium, omega-3, DHA or DHA, evening primrose borage oil for omega-6, iodine, Vitex agonist cassis or chasteberry is a good herb, as is Chinese herb Dong Quai. So getting coenzymes, something just to add here, getting coenzymes into the hypothalamus. So we need to get our coenzymes, particularly to get that dopamine level up. And what we found is that pyridoxal 5-phosphate, which is the key coenzyme here, requires walnut oil. So there's something in walnut oil which helps to carry pyridoxal 5-phosphate into the hypothalamic nuclei. So mixing the two together and swallowing down activates the pyridoxal 5-phosphate, some factor in there to carry the pyridoxal 5-phosphate into the hypothalamus. I put the other coenzymes that we found and the oils associated with them there for your reference as well. So suprachiasmatic nucleus, this seems to be the key. This is the body clock nucleus set point techniques. So we've got two techniques that we can use. Firstly, identify if the positive meridian with a person is yin or yang. If it's a yang meridian, it indicates an underactive suprachiasmatic nucleus. So use the 386 nanometer light for therapy. If the yin meridian indicates an overactive suprachiasmatic nucleus, so use 400 nanometer light therapy. So those two wavelengths have been discovered to stimulate or inhibit the suprachiasmatic nucleus, in other words, to reset the point of their firing so that they increase or decrease their hormone production. So there's the 400 nanometers, which we use to treat the suprachiasmatic nucleus when it's overactive, and 386 to treat the low levels of the suprachiasmatic nucleus expressions. So we can do two things. We can use a light box. So now we're going to demonstrate using a light box with the appropriate color wavelength. So this is the colors that I put on to PowerPoint, and as you can probably see there, we put on the 400 nanometer there, and it's necessary to look at that wavelength for about 15 minutes, which is a bit boring. So you can use a light box, which you can purchase and use an acetate, or you can look at the appropriate wavelength on the computer using PowerPoint, which is a lot more convenient to do. And you can also change up or down. So you can see that you've got the two there. So you've got the 300 and 86 for the underactive. Okay, so the alternatives here would be light therapy. Place the appropriate wavelength acetate over the acupuncture point that we found that's common to the hypothalamus. If we're going to use the 400 for the overactive, conception vessel 21 is 1 sun below the manubrial notch. So find the manubrial notch and go 1 sun down, and then we apply the white light using just a straightforward light therapy here for 2 minutes. And what can happen then is the patient can then do this themselves at home, and take a torch, get the acetate there, the little acetate there, and do this for 2 minutes every day to try and help balance the suprachiasmatic nucleus. Well, I really hope that you enjoyed the seminar and the presentation and the information that I've given to you today. And I really missed you guys and look forward to next year, and hopefully we can all be together again soon. Bye.